What is going on, wonderful people? Welcome to another Confused Neuron Explainer. Today, grab your markers because we're heading to the whiteboard to cut through the dense pharmacology of antidiarrheals. It's going to be like slicing warm butter. We're going to map out exactly what's happening in the gut and how we use specific meds to stop the madness. So let's just get right into it.
But first, a quick hook question for you to think about. What is the absolute most dangerous thing about severe diarrhea? Take a second. Well, it's not the mess, it's the severe dehydration and electrolyte imbalance. Literally, it can turn you into a vegetable and lead to catastrophic organ failure. Without those precious fluids and electrolytes, your brain and heart just cannot function. Make no mistake, this is a real clinical emergency. All right, let's look at the Confused Neuron lesson plan on the board. We've got 6 parts today. 1. The diarrhea dilemma. 2. Disease classification and causes. 3. Treatment algorithm fundamentals. 4. Anti-motility agents. 5. Adsorbents and fluid modifiers. And 6. Side effects and contraindications. Okay, Section 1. The diarrhea dilemma, pathophysiology of a GI emergency. Let's start with a quick definition. Diarrhea isn't just an inconvenience. Clinically speaking, it's defined as having 3 or more loose or liquid bowel movements in a single day. Now, check this out on the board. We're comparing normal GI function with diarrhea pathophysiology. Normally, your gut has this beautiful, perfect balance of absorption and secretion. But look at the glaring red on the right. In diarrhea, you get a massive spike in motility and a devastating drop in fluid absorption. Basically, your gut panics and is literally just dumping water. And when you dump water, you lose incredibly scarce resources. I'm drawing some big red exclamation points next to these danger signs of dehydration. We're looking for extreme thirst, totally zapped energy, decreased urination, and dizziness. In severe cases, especially if we're talking about babies or the elderly, you'll see a loss of skin turgor, sunken eyes, or even a sunken fontanelle in infants. We absolutely have to protect the brain and the heart by keeping that fluid inside the body. Moving on to Section 2, Disease Classification and Causes, identifying the microscopic culprits. So, what's actually causing the gut to freak out and dump all this fluid in the first place?
Let's whiteboard the usual suspects, our pathogen lineup. First, we have viruses, which, surprise, surprise, are actually the most common cause worldwide. You've got norovirus ruining adult vacations and rotavirus, which is a major threat to kids. Then you have bacteria like Salmonella, Shigella, and E. coli. And finally, the parasites like Giardia. Now here is a massive takeaway. Since viruses are the most common cause, blindly throwing routine antibiotics at every single patient is absolutely not the answer. In fact, it can make things way worse.
Section 3. Treatment Algorithm Fundamentals, Step-by-Step GI Rescue. It's absolutely crucial to know your step-by-step strategy to save the patient before you even think about reaching for the heavy pharmacology. So here's the core algorithm you need to memorize. Step 1, always rehydrate first. Oral rehydration solution, or ORS, or IV fluids if it's severe. Step 2, zinc supplementation for kids over 2 months old. This is a game changer. It can actually cut the severity and duration by up to 40%. Step 3, targeted antimicrobials, but only if you have a specific bacterial or parasitic culprit identified. And finally, Step 4, antidiarrheal drugs to manage those awful symptoms. Look at this vital number I've highlighted right here, 210 to 250. That is the ideal low osmolarity measured in milliosmoles per liter for an oral rehydration solution. Why? Well, you need a low osmolarity so the fluid actually gets pulled back into the body's tissues. If it's too high, it draws more water out into the gut and, you guessed it, makes the diarrhea even worse. All right, Section 4, anti-motility agents, hitting the gut's brakes. Once the fluids are handled, we bring out the heavy tactical weapons. The 2 big heavy hitters you need to know are Loperamide and Diphenoxylate. These are actually analogs of mepiridian, meaning they're opioid-like. But here's the cool part. Instead of going to your brain, they target the enteric nervous system right in your gut. They activate presynaptic opioid receptors, which inhibits the release of acetylcholine, and boom, peristalsis drops. The bowel quiets right down. And the best part? At usual doses, there is 0 systemic analgesic high. But, people are clever. If someone chugs massive doses of Diphenoxylate, they actually can catch some opioid euphoria. So pharmacologists got clever right back. They created a fixed-dose combo of Diphenoxylate mixed with atropine. Remember this mnemonic? We mix in the atropine to add the ache to the abuse. If you take too much to get high, the atropine kicks in with horrible, unpleasant anticholinergic side effects. It totally deters misuse in its tracks. Next up, Section 5, Adsorbents and Fluid Modifiers, cleaning up the GI mess. Let's shift gears from hitting the brakes to actually mopping up the toxic contents inside. First up, adsorbents, with a D. These are agents like aluminum hydroxide and methylcellulose. Imagine them as giant physical sponges inside the gut. They coat the intestinal mucosa and physically bind directly to the nasty toxins and microorganisms. Just keep in mind, while they are great at cleaning up, they're generally a bit less effective at stopping the flow than the anti-motility drugs. Let's lock these mechanisms in with a quick side-by-side comparison on the board. You've got your anti-motility agents, like Loperamide, acting as an opioid receptor agonist to decrease peristalsis. Then, absorbents, like aluminum hydroxide, acting as your sponge to bind toxins and coat the mucosa. And finally, fluid modifiers, like bismuth subsalicylate, which actively decrease fluid secretion into the bowel. Which brings us to our final part, Section 6, Side Effects and Contraindications, the Price of Treatment. Look, every medication has a trade-off, and if you forget these on test day or in the clinic, I will virtually smack your gluteus maximus. Let's start with a massive bismuth alert. Bismuth subsalicylate is a super popular fluid modifier, especially for travelers' diarrhea. But here is the catch. It can turn your tongue and your stools pitch black. Literally, pitch black. It looks absolutely terrifying, and your patient will definitely freak out. But you just have to reassure them that it's a completely harmless chemical reaction. Now for a totally unharmless, deadly serious contraindication. I'm drawing a giant explosion symbol on the board for this one. Toxic megacolon. Listen to me, you must never, ever give anti-motility agents to young children or to patients with severe colitis. If you paralyze an inflamed, infected bowel, it can rapidly expand and literally burst. It causes toxic megacolon, and it is absolutely life-threatening. Let's rapid fire a few more high-yield side effects you've got to know. Aluminum hydroxide, it causes severe constipation. It's honestly a little too good at its job. Routine, inappropriate antibiotics, they wipe out your normal flora and trigger a massive C. diff superinfection. Diphenoxylate, that can give you painful abdominal cramps. And remember, antacids and adsorbents can physically bind to other drugs in the gut, completely ruining the absorption of other life-saving meds your patient might need. Wow, okay, we covered a massive amount of high-yield ground today. So to really test your confusion neuron, I'm going to leave you with this final two-part provocative question. Why exactly do we pair atropine with diphenoxylate? And which drug is famous for giving you a harmless but terrifying black tongue? Lock these pharmacology facts in, let me know your answers in the comments, and as always, stay curious.